Well, it's so good to have you here. My name is Christopher Robertson. I'm a law professor at Boston University, and we are delighted to host this event with women's health advocates. We're going to be talking about CMS, Center for Medicare and Medicaid Services, reimbursement, how they pay for healthcare, and the discrimination that exists in those reimbursement rates, and ultimately how it impacts patients, which is the bottom line. So we've already risked alphabet soup, which is anything in this space, but we're going to be very careful to both define things while also try to move quickly. I'm right off the bat trying to remind myself to do that. Welcome people from Zoom. We have reporters from around the country and others. Thank you for being here as well. I want to also acknowledge Liz Powell and Madeline Stickley from G2G Consulting, who has just been a phenomenal role in helping us put this together. Liz is the founder of Women's Health Advocates. This is one of the verticals that they work in. Also, Isabel Neen from BU helped really, she was the moving force behind bringing this to fruition. The fact that you have seats and a roof and food is all thanks to Isabel's organizational skills. I want to thank the Boston University Neil Pike Fund, which is an endowment that's existed for over 100 years that supports this. Mr. Pike was the first blind advocate admitted to practice before the U.S. Supreme Court, an alumnus of BU and the government created this fund many years ago. And finally, I want to thank the Office of Representative Lori Trahan, who reserved this room for us and will be making an appearance later today, assuming her role on the Senate floor allows. So, with that, let me introduce our speakers very briefly. We have a phenomenal group up here. We have Tricia Black, who will be speaking from the patient's perspective. We have Louise King coming to us from Harvard and Mass General, where she also, I've been happy to say, I've been tutor to teach at Boston University Law School as well. We have Jocelyn Fitzgerald, who comes to us as a surgeon from the McGee Women's Hospital, University of Pittsburgh Medical Center. Tindy Brown comes to us from Northwestern University, Feinberg School of Medicine, and Ashley McClurg, another of our 4 surgeons, who comes from us from University of North Carolina at Chapel Hill. They'll tell you a little more about their subspecialties, which vary a bit. We have urogyns and small incision surgeons doing a range of work, but a phenomenal panel of experts here for you today. Here's what we'll be covering. First, Tricia will talk about her own story. What happens when you don't value women's health, the experience sort of on the ground. The architecture of reimbursement, how in America we decide what we pay for over 12,000 different procedures. The proof that women's health is devalued, the scientific evidence that we actually discriminate against women's bodies. The impacts of that on how the entire profession of medicine is organized and how it trickles down to affect new medical devices being brought to market and a range of other effects. 5th step is how this actually affects patient safety, how it leaves patients with lifelong injuries and pain, suffering, and disability, and sometimes death. And then I'll talk at the end a little bit about the role of Congress, the role of CMS, the role of courts, what we can do about it. So as I invite Tricia Black to come to the podium, I just want to say we're organizing this event. We put out the word to patient communities about this event was going to happen and that we'd welcome to have someone speak on their perspective. 10,000 women stepped up and said, I have a story to tell that fits this profile. Of course, each story is unique. Each story is heartbreaking. But it's important that you hear one of those stories. And so we're just delighted to have Tricia Black here.
Hello. Thank you so much. Thank you. Oh, I get a real microphone. This is dangerous. Okay. Thank you all for being here. My name is Tricia, and I am going to walk you through my story, which reveals what happens when a woman's pain is dismissed. This story isn't just about a diagnosis, it's about impact, access, and equity in care. So I'm hoping at the end of this presentation to actually inspire you. Our healthcare system should be able to support and serve our generation. So this is me. I am an athlete, I'm analytical, and I'm living with endometriosis. So about a few weeks after running a 14,000 vertical foot mountain for 13 miles, I experienced extreme pain in my hip and back. You might think this is due to running. I later found out it was due to endometriosis, a disease that impacts the entire body. It causes adhesions on internal organs to stick together. So over time, I realized that I needed to advocate for myself. This period of my life became very dark. This is a downward spiral of what I experienced with endometriosis. I did not have a diagnosis at this time. I was at the ER because of extreme pain in my hip and back after running that long mountain race. I was dismissed and I was misdiagnosed. I had to fight through pain and red tape and employment risk. Finding a doctor who had evidence-based expertise and accept health insurance was a challenge I did not expect. Finding a doctor became insurmountable. Many excision specialists for endometriosis do not accept health insurance. They are required to accept out-of-pocket payments. Once a woman has this intense, extreme surgery, they are encouraged to go back to work quite quickly. $560,000 was billed to my health insurance before the root cause was even addressed. We all too often hear how ineffective our health insurance system and health system are despite the extreme costs. This is where we can take action. The symptoms women experience are discounted and later they manifest into something much worse. I experienced several delays in testing. I dealt repeatedly with unwilling medical professionals to improve my health. They wanted to perform extreme surgeries without actually addressing the root cause. So the majority of this costs are related to 2 ER visits and 1 ineffective surgery and about a dozen doctor's appointments before the root cause was even considered. All of this could have been avoided with the proper care the first time. So this is not just financial, it's personal. The emotional toll and the frustration of being heard and the fear of losing stability had a major impact on my life. It affected my confidence and it diminished my professional opportunities. So what if we believed women the first time? What if we had access to professionals who had specialized training? We could save money. We could prevent trauma and help women get back to their lives. So that's a future that is possible and it's worth fighting for. Thank you so much for your time.
Thank you so much. As you mentioned at the beginning, this is not specific to endometriosis. I'm a minimally invasive gynecologic surgeon. I do excision surgeries for endometriosis at Master North program, but we also treat fibroids and ovarian cysts and chronic pelvic pain for a variety of reasons. We have a variety of different surgeons here, including urogynecologists, and most women experience delays. Endometriosis is particularly bad. Delays are long. But many women experience delays. And so what we're talking about today are the systemic issues that underlie all of the problems that were just so eloquently described for you. So I want to talk first to you about the architecture of reimbursement to just make sure that we're all on the same page. Many of you might know these details, so I apologize. I'll go quickly just to be sure we all understand. In the United States, gynecologic surgeries are about 4 million surgeries per year. We're usually the hardest working surgeons in any given hospital. although we receive the lowest reimbursements and have the smallest pie to work with, we're typically the ones doing the most procedures, staying late into the night for add-on cases because we can't get OR blocks, etc. The framework of how billing comes to us, how it's created in the United States, and then how that results in money that we can use to treat our patients, to hire PAs and nurses and whatnot, is expressed here in this flow chart. And so it starts off with pay in the framework through CMS and the AMA RAC, et cetera, that I'm going to describe for you a little bit. It goes down through a bias system into the eventual outcomes that we're going to discuss. And our proposal to you is that this system and the systemic issues that result from it are what result in the poor outcomes that we heard described. So in terms of that framework, we're paid on a fee-for-service basis. The common expression in surgery is you eat what you kill. But obviously that's not a great way to express it, but it's very catchy. And what it expresses to you is that for everything that I do in any given day, I can quantify it, not just based on the hours, but the complexity and the equipment that are involved with it. To get to that number that corresponds to the typical reimbursement, we go through the CMS, I should say, relies on the AMA Commission to set, with the RUC Commission to set these relative value units for all the procedures that are done, not just by gynecologists, but every surgeon out there. And then private insurers, this is not simply an issue related to Medicare and Medicaid. Private insurers will follow the same set points in their negotiations with individual hospitals and groups as they set the pay. So again, I provide a particular medical procedure, I send a bill for that procedure to CMS or to a private insurer, and then I'm reimbursed a percentage, typically of whatever I sell. The RVU, or relative value unit, is again assigned by the CMS in response to recommendations, at least 90% of the recommendations sent to them from the AMA. But it initially started with a study that was commissioned in the late 1980s into the early 1990s when the Social Security Act was passed, establishing this system that came through the Harvard University School of Public Health. And that set point did really very little to account for gynecologic surgery. It was much more focused on bigger surgeries that you might think of at the time. Certainly they were focused on cardiology, on orthopedics, on vascular surgery in those areas. And so there was very little work put into quantifying the work of the surgeons who care for women. The same is true of obstetrics, by the way. We're not talking about that today, but the same issues exist. So you can imagine us all starting at this starting line, at this set point that was created in the 80s and 90s, and we're starting way in the back and just consistently trying to catch up. And by we, I mean gynecologic surgeons or surgeons who primarily focus on women's health. In 1992, CMS adopted this system that was flawed at its base. Within those RVUs is a quantification of the skill that's brought to bear. So we were adjudicated to have less skill at that initial set point, or less required skill at that initial set point back then. The cost of running a medical practice similarly adjudicated to be less costly for women's healthcare. The time apportioned to it, and I'll cover that in a little bit more detail in a moment, and malpractice insurance, which is particularly high in the discipline of obstetrics, but comparable to other surgical disciplines within gynecologic surgery. And then every year you'll hear this discussion of what the conversion factor is going to be. That's coming up right now in votes and discussions for you. So that's the multiplier every year that goes against these RVU set points. And that's then translated into what we can bill for our services. In terms of deciding what the RVU is going to look like, it comes eventually from CMS, but it starts in the AMA RUC committee, which has voting members from a variety of different groups. The obstetrics and gynecology group is one vote, whereas most other surgical disciplines have their own vote. So our vote is to some degree diluted by the fact that we are also concerned with, and should be concerned with, maternal health, maternal morbidity, and maternal mortality. That's a big thing for all of us as trained obstetrician gynecologists. Even if we've fully specialized into gynecologic surgery, we're very concerned with those issues. And you can imagine how that really can get diluted by the incredible importance of issues in that space. So gynecologic surgeons don't have their own vote. It is somewhat diluted. I've already mentioned this, but again, 85% of OBGYN residents are women. 65% of OBGYNs are female, And yet within the composition of the RUC, only 12.5% of the RUC seats are held by women. I think that perspective is important. We only have the one vote, it's diluted by other concerns. We really don't have the voice of women within that room that we need. I'll add another wrinkle for you. Within the Social Security Act that was passed in 1992 that set up this system, there is a budget neutrality clause. That means that we have to contain any increases in spending under a certain threshold that has never been changed. And you can imagine what that leads to within this room of people voting, right? We're all fighting for the same pie, and we're all nudging and pushing against each other for the same pie of money that we might split and increase billing from. And then again, think about that one vote, that one person voting for obstetrics and gynecology, and trying to figure out where they're going to put the pressure points. Again, we are facing a maternal mortality crisis in this country, so we're going to be focused on obstetrics. That makes perfect sense, but it's not working for the women in work. CMS will almost always accept the RUCs, the AMA RUCs recommendations, but CMS doesn't have to do that. That's just been the standard to date. And then again, as mentioned previously, Medicare sets the standard for commercial insurers. So we're not just talking about federal set points, but how that translates into our ability to negotiate for reimbursement and thus for resources for our patients with private insurance. Is there transparency? Unfortunately not. I have been lucky enough to serve as a non-voting member on the ACOG check, which is the group that reports into the voting person who goes to the AMA RUC, and I've gotten to sit down on a number of AMA RUC meetings. And I've also been on a presidential commission for ACOG looking at these issues, but it's not possible for us as this room here sits today to get any of the internal deliberations from the ACOG check or data to really see what's going on behind the scenes in terms of their discussions and deliberations around recommendations that they're going to make through their one vote. Similarly, although the RUC is somewhat transparent, it's not as transparent, I would argue, as it needs to be, especially given the amount of influence this has on the care that we can deliver to our clients. So the bias that I've mentioned previously occurs primarily through the system by which the AMA RUC accounts for that time component. AMA surveys are sent out to physicians, and the methodology produces inaccuracies. There's an exceptionally low response rate, so the surveys don't really represent the actual time that's occurring in the ORs. And there are vast ranges in the responses that they receive. ACOG members, the median response rate here is 2.2%. That's across all the surveys sent to all surgeons. Obstetrics and gynecology has a much lower response rate than that. And it's not randomly selected. I've been in practice 15 years. I've never received a survey. That's a self-reporting bias. And that reporting bias results in gynecologists, for a variety of reasons, sort of under-reporting and underestimating the value of the care that they provide, which again trickles down into less voting and less pressure to change the billing that exists through the AMA. That might be a result, perhaps, of the gender disparity within our discipline, insofar as we are mostly women in OBGYN. I won't speak for myself. Well, I will speak for myself. I'm not the best negotiator. I'm not the best person to like push. It's not really my nature. And I don't know, it's possible that has a part of this in the sense that we don't negotiate aggressively. ACOG does not negotiate aggressively on behalf of gynecologic surgeons. So, you know, there's been a lot of calls to adjust how the RUC functions. And I think that is definitely part of what needs to change here. I won't quote it, it speaks for itself. There really needs to be a significant change. I'm not exactly sure what that change should look like, but we are going to propose a lot of ways in which we could create meaningful change to you through this discussion. And I hope that you'll be interested in creating that change with us. So certainly the underrepresentation of gynecologic surgery in the voting and the determinations for evaluation is what I really want to take you away from that section of our discussion. And from here, I'll pass it on to Nicole.
Just mentioned we have a couple seats in the front and in the second row, if anyone would like. Promise not to cold call you. And we will have a Q&A time at the end.
For sure.
My name is Dr. Jocelyn Fitzgerald. I'm a urogynecologist and female pelvic reconstructive surgeon at the University of Pittsburgh. I wanted to actually just really quickly back up in case anybody in the room doesn't know what we mean when we say a gynecologic surgeon. I think most people know what an OBGYN is. A gynecologic surgeon, I have some more slides that will demonstrate this. We do additional 2, 3, 4 years of surgical training after OBGYN in diseases like ovarian cancer, endometriosis, fibroids, female pelvic prolapse, incontinence, things that I promise you every single person in this room, their mother, sister, aunt has needed an advanced female pelvic surgeon for. So we are the lowest paid surgeons in medicine, and that means that our hospitals see us as such, and it translates to our patients. That's really why we're here today. Something that I think should make everybody very angry. And when I learned this in my training, I certainly was. When we talk about this and we say, oh, you know, I trained for 7 years in surgery, an orthopedic surgeon only trained for 6 years, but they're making triple my salary and generating triple the revenue for the hospital. People say that's apples and oranges, you can't compare it, but we can compare female urology to male urology. Male procedures versus female procedures that are equivalent. The same exact surgery done on a man versus a woman on their particular anatomy. We just did a great research paper that I think all of you will have access to a copy of that shows that if you're a man getting a urinary tract surgery, your surgeon will make almost 50% more money doing that same exact surgery that would be done on a woman. On average, 35% more, but you'll see in the next slide that it can be up to 150% more. I do want to say, just for the tag on this slide, what Dr. King was saying, there is a set point typically of dollars that are reimbursed per RVU for these procedures, men versus women. But often if somebody has a urology residency behind them, they will get more dollars per RVU for the exact same surgery, even if they do it on a woman. So the disparities grow very quickly. This is our paper. We would love to share it with you. And this is one of the main takeaways from this paper. You can look at this graph. On average, the female procedure, we just have it up here, is 100%. Let's just say that. Then a male procedure on average bills 130% more. The exact same equivalent surgery. I'm talking like a testicular torsion or like twisting versus like an ovarian twisting or ovarian torsion. 35% more. And if it's specific to the urinary tract, it's 149% more. So you can imagine to a hospital system, if you're working just as hard, but you can't generate as many dollars for that hospital, your patients are going to pay the price. Here's some examples of some procedure pairs. So sorry to bring genitalia to the set, but if you do a biopsy on a penis versus a biopsy on a vagina, you make 45% more money to biopsy a penis versus a vagina. And let me just say, it is more difficult to biopsy a vagina than a penis. It's a lot harder to put them in position to get that done. So it really adds up over time in a really significant way. These are just a quick graph of these procedure pairs over time. You can just see the RVUs are how we're doing this, apples to apples. The average sort of RVUs will go to 2023 for a female procedure is around 10, and then the male procedures are around 13, 14. So consistent every single day, making more money to see the same amount of patients, do the same amount of work. And a lot of people say like, oh, you're doing as much work, but do you have as much training? Do you have as much expertise? Are your procedures as complicated? It's very easy to think that like women's issues are not as complicated or that their surgeons are not as well trained, and that is not in fact the case. I'm a urogynecologist. I did 7 years of surgical training. Let's just look at the top surgery. There's something we do. This is from a surgery called a sacral colpopexy. It bills 17 RVUs. It takes about 4 hours to do, sometimes more. It's a very complicated surgery, very high risk, very high stakes. If you go down to the bottom, let's just look at a minimally invasive shoulder surgery that an orthopedic surgeon with 5 or 6 years of training will do. It takes 30 minutes to an hour to do that surgery, and it bills almost 16 RVUs. It's almost the same. And so they make the same amount of money for the hospital in 30 minutes that I make in 4 hours. So you can see how that would just not shake out financially. I want to give an example of endometriosis because that's where we sort of started with Tricia. I think this is the most egregious example. It takes 7 to 10 years to diagnose, and there's one billing code. And endometriosis surgery, I showed on the prior slide, I'm sorry I didn't pause to show it, but it can take up to 5, 6, 7 hours. Go anywhere from an hour to 7 hours, depending on the complexity of the adhesions and the amount of organs involved in the disease. There's one billing code, and it has not been increased, and it disincentivizes patients from seeing a specialist surgeon. They're going to see a lower trained surgeon who they can see in a short amount of time, and surgical facilities are not going to want to give an endometriosis surgeon who's billing one low reimbursing code an operating room for 8 hours. If that same orthopedic surgeon can do 16 shoulder scopes in that time and make 16 times the amount of money. So Trisha mentioned this, endometriosis excision is shifting to a cash-based practice. There's a lot of surgery centers that simply will not allow doctors to even operate there, even if they take private insurance, because they are not making money to keep the lights on. So endometriosis is shifting to cash-based practice. Women are mortgaging their homes, going into credit card debt, and it is really that cost being passed on to them. So this is the one of the last slides I'm going to show. This just shows annual compensation. I think no one likes to say like doctors aren't making a good living. Of course, doctors are well compensated, but this really has to do, our salaries are a direct reflection of what our patients' resources are getting in the hospital from the money that we make. You can see here up here in the corner, urology is making up at the very top, orthopedic surgery, urology, and obstetrics and gynecology and gynecologic surgery, I'm sorry, is down there in the corner. It's the lowest, we're the lowest paid surgeons in medicine. So it's really all about what is the work worth, what is the training worth, and what are patients worth. So with that said, I'm going to have my colleague, Dr. Brown, talk about the impacts to our patients of this evaluation.
Thank you. Good morning. So she said, I'm Jenny Brown. I'm your gynecologist. We're in the same specialty. So we treat embarrassing conditions, prolapse, people peeing on themselves. I think it's an amazing specialty. You've heard from my colleagues about the problem, right? They've quantified it. They've given you the data behind it. And so I'm going to talk about the impact of devaluing the whole specialty. It's completely focused on women. And I'm just going to preempt this and say, let me be clear, it's not about professional recognition, okay? Some people may be tempted to think that's what it's about. It's about a systemic inequity that threatens the financial sustainability of the health systems, the viability for our workforce, and most importantly, access to care and the quality of care for our patients. And you're going to hear more about that, okay? So I love this image. I can't remember where I found this. But it's the concept of the notion that the decisions that we make, small things, may seem like something tiny or trivial, has profound downstream consequences. So this idea that gynecologic surgery isn't valuable has profound, significant downstream consequences. I'm going to highlight a few for you. So let's talk about the health system level, right? What does this mean for health systems? So hospital administrators have a tough job, okay? You have to provide care, you have to take care of people, but you have to keep the lights on. And they make decisions with that in mind. And unfortunately, resources aren't infinite, right? They are limited. And when you think about allocation of resources, you have to have some kind of system to say who's getting what, how much are they getting, when are they getting it. And unfortunately, gynecologic surgery, and we're living it, usually is at the bottom of that list, that hierarchy list. We are fighting for operating room block time, equipment, staff. And you think about it, when oftentimes at most hospital systems, and there are too many papers to actually quote on this, when you talk about how are these resources allocated, it comes down to who is bringing in the most, who's most profitable. And what we see is a chronic disinvestment in a specialty, right, in a field dedicated to women. We're allocated less operating room block time. If you're a surgeon, if you don't get block time, you can't get your patients in on time. You just can't, right? There are a lot of backdoor things that we do for our patients. But when it comes down to taking them to the operating room, we are limited by the time that is given to us to do that. You want to be able to offer your patients the most up-to-date equipment and technology, right? Technology innovation is huge. It's important for pushing and advancing care. And the capital budgets that are assigned to that, again, right, it's the return on investment. If we're going to spend money on expensive equipment, are we going to get that money back? And then your staffing is huge. We talked about our 3 to 4 hour surgery. If you are doing that with a new crew every single time, you're behind, and it puts the patient at risk. But to dedicate a group of individuals to support a service line means that you think the service line is valuable. And unfortunately, that's not necessarily the case at every hospital center. And what this leads to, again, that message that gynecologic surgery is not valuable. And this chronic disinvestment, we're seeing across the country that certain OBGYN service lines, hospital systems, services are being discontinued. And again, it goes back, I love this image. you presented Dr. Fitzgerald, right? Again, what is this saying? Our compensation is reflective of the value that is placed. And people are watching. It's not just the physicians and the hospital systems that notice this or feel that they're impacting definitely our patients. But in our hospital systems, we have our medical students, our residents, our fellows, people who are deciding what it is that they want to focus on with their lives as they train, right? And when you see a culture that says this field is really not the top, dog here, or these patients, they need to wait a little bit longer, or the surgeons in this specialty are getting a little bit more, not even respect, but just again, value. Why would you want to join that specialty? Decreased interest in our field. And this is happening, right? And even within OBGYN, remember, all of us here trained in obstetrics and gynecology, we focus on gynecology now. But we're seeing even within our specialty for the folks who are our specialists, is our bread and butter OBGYN, the folks who are going to say they're going to practice the full scope of our specialty. There's a greater financial incentive for the obstetric services. It's critically important. It is. Maternal care is so important. However, what that means is in order to keep the lights on, to think about what is financially sound and makes sense, there's this emphasis or overemphasis on obstetric services, and then it leads to individuals who actually are low volume gynecologic surgeons. You hear more about that and why that's important. If your surgeon doesn't have the adequate volume, right, in a given period of time for a particular procedure that you are going to sign up to have. And you put these things together, we're seeing fewer folks in our specialty, less experienced general gynecologists, right? And this is, again, multifactorial, so not totally because of this, but devaluing the specialty and the services is one contributor to this phenomenon. There was a recent workforce analysis that was released a couple of years ago that says that the demand for women's health is expected to go up about 7% by 2030. But simultaneously, the workforce, the OBGYN workforce is thought to decrease by 6% during that time, by that time period. And that we're actually ahead of schedule. Folks are retiring, not as many people are entering our specialty. It's a real setup for disaster. And then some people, when you hear about allocation of resources, you may be thinking, well, I mean, maybe the other specialties like orthopedic surgery just bring in more volume, so they should get more time. They should get more resources. This is one center, one academic center that published their volumes in a period. And in that red box is gynecologic surgeries and breast surgery. Pretty much almost the same as orthopedic, the third highest volume raiser, bringing in the most surgeries. And again, it's not reflected in the compensation. It's not reflected in allocation of resources and value. And again, doing all that with less time allocated than orthopedic surgery. And then Dr. Fitzgerald highlighted the physician impacted. Ultimately, folks want to take care of people, but it has to be sustainable. And there is a huge shift for certain conditions where folks are shifting towards a cash-based model. And if you think about that, the people who are going to pay that price are patients. And so with that, I will let Dr. McClurg finish away about how this impacts our patients. Over here's what I just did. Thanks for your time.
Thank you, Dr. Brown. I'm Dr. McClurg. I'm a minimally invasive gynecologic surgeon at the University of North Carolina. So we've heard a little bit about how the system is created that decides how physicians get paid. Then we've heard about the bias in that system, that we pay procedures for men more than procedures for women, and the impact of how that makes decisions on hospital level in each of our communities. What I want to do next is talk about how that impacts the care that our patients receive every day. So I want to take a step back to training. This is a map of all of the residency trainings for OBGYN in the country. And you'll notice that OBGYN training is already centered around urban areas. And if you look right in the Mountain West, there's only 3 residency programs that represent about a third of the landmass of the lower 48. And so what that means is that patients already are set up to have a high likelihood of maybe needing to travel long distances to see somebody who specializes in what they need. So we already have a discrepancy, even when you try to get to an academic medical center, you trade people. And then during that time, the residents in training for their OBGYN, 4 years, 48 months, about 18 to 20 of those months are dedicated to gynecologic surgery and GYN. So it's already the minority of their training. When we look at how many procedures residents do in a year, they deliver about 500 babies. That's the averages from last year's case reports that residents met at the end of their training. 500 babies, about 300 of them vaginal and 200 by C-section. So residents are graduating learning how to do 200 surgeries to deliver babies. They're doing 100 hysterectomies. They're doing 1/5 the amount of gynecologic care than obstetrics and half as much surgical care for gynecology than obstetrics. So that means that our residents, when they go out into practice and become general OBGYNs across the country, they're already not set up for success to be experts in the diseases of gynecologic surgery. And so what that means is that the vast majority of OBGYNs in the country are not experts in gynecologic surgery, and the vast majority of you and your families, when you seek gynecologic care, will be seeking care from a general OBGYN who uses about 15% of their practice doing gynecologic surgery, about 1 to 2 OR days per month. And so what happens when people who are not experts in gynecologic surgery do surgery every single day and are the main people doing surgery for the population? The facts is that they don't feel prepared to do it well. This is one study that looked at people who decided to go to fellowship and asked residents and program directors for fellowship how skilled those residents were. And 50% of patients, of doctors, did not feel confident doing a hysterectomy for a large uterus. Very, very, very common procedure and a common need. And only 20 to 40% of OBGYN graduates could perform a key range of OBGYN procedures. These are 2 studies to kind of highlight how big the unmet need of GYN surgery is. But I assure you that these 2 papers that I've highlighted are 2 of a very, very wide and robust set of literature revealing this. So this means that low volume surgeons who do 1 or less hysterectomy per month, are doing the vast majority of gynecologic care in the country. And high volume surgeons who've done fellowship training an additional 2 to 3 years, that's some of the surgeons you see here, have better outcomes, use smaller incisions with lower risk, have shorter operative times, and they have a lower procedure cost of the system. So they actually help the system provide better and more economical care. This is the take-home point that I really want you guys to understand. When you're able to find a surgeon who's an expert in what they do and they focus their whole practice on it, the outcomes are better. You're 3 times more likely to have a complication when you see a general OBGYN for complex conditions, 3 times the risk of bleeding, 3 times the rate of injury, 3 times the risk of having an incomplete surgery. And an incomplete surgery means that you might have years needing additional procedures, additional time off work, additional impact to your life and disability. And that's something that you heard about from Trisha. It took her years and years and years to find somebody who could get rid of surgery that she needed. And this is not an uncommon story. It's the normal story for our patients across the country. This is a map. I started with a map of showing you where general OBGYNs are across the country. This is a map for people who have trained in surgery with small incisions for endometriosis and fibroids, where they're practicing in the country, and the distance that a patient would have to travel to see that surgeon. So in many cases across the country, if you want to see a surgeon who's going to give you the best outcome, the lowest risks, you're traveling 100, 200, 300, and even 500 miles to see that surgeon. And you can see that that's not practical for any patient to really do. That's a tremendous barrier. And there's ways that we can get this by systemically looking at the issues that led this map to exist. Right, I can hand it back over to my colleague.
Thank you. We're on the home stretch now, and you're probably coming at this, learning about it the way I was 2.5 years ago when I had lunch with Dr. Kane and learned about the steps that you just saw all laid out at once. And frankly, I couldn't believe it. It seemed like the system was designed in a way to make safety irrational. Like, if we want patients to have good outcomes from the 4 million surgical procedures a year, they need to get to surgical specialists. But to become a surgical specialist in this kind, you have to go through 2, 3, or 4 years of advanced training. But when you do so and commit to getting high volume in these surgeries, your annual income goes down dramatically. That's what I mean when I say safety is irrational. Like, we'd have to give up. And so that's why That's why we don't see a lot of people doing this, except for, the people and your colleagues around the country that you're speaking today. And so we have to make safety the norm, not the exception, right? We can't depend on saints to get safety on a day-to-day basis. So the law professor here, then my cleanup duty is to talk a little bit about what Congress can do and what the executive can do. And I'll end with an ask for you that I think is perfectly legal for Boston University to propose and lay out the sorts of things that could be done. These sex-based codes where we actually say if you're going to remove a lesion on a penis, we'll pay you 50% more than if we're going to remove a lesion on a vulva. That is itself sex discrimination in the simplest, most crude, obscene way. I think there's no other word for it. And imagine if you substitute race for sex. It's obscene in that sense. And so we can ask the courts to say this is unconstitutional, but the courts are a little busy right now, and there are some profound procedural barriers to that happening. So Congress, I'll nerd out as a law professor if you need me to later, but you can't wait for the courts to do this. Likewise, the private insurers, I think they face some legal risk here, by the way. If you know a Cigna or an Aetna or a Blue Cross or a United, they need to be careful. This is, I think, a warning from the law professor. But ultimately, I think CMS can eliminate these CMS codes that discriminate by sex. A lesion is a lesion on genitals. And there are dozens of these that we don't even need to discriminate on. Second, when there are female codes, a hysterectomy is going to be a hysterectomy. Those need to be set at objective levels. Don't go to a survey of 12 people and ask how much time they spend. That's a ridiculous way. Those surveys would never be published in a peer-reviewed journal, but we need billions of dollars in the economy. Those need to be based on objective measures of surgical time, and we need to, reset some of these mistakes that were made way back in the 80s and 90s. So to delve a little more deeply in that, it is important that the executive here challenge these discriminatory recommendations from the AMA. You don't have to accept them, and Congress has a role in making sure that the executive does so. We've talked about removing sex-based codes, resetting female codes, but what Congress has done has set a $20 million per year budget neutrality cap, meaning that if we raise any rates in the system, we have to lower other rates. And as soon as we try to do this, the urologists and the orthopedic surgeons show up and say, nope, you can't do that, members. And so the politics of this, if you can look 2 steps over the horizon, is Congress is going to need to lift that level in order to get everybody on the same page to make a more fair system. And so this would be a congressional step requiring legislation. Ultimately, there's been a lot of criticism of the RUC on both sides of the aisle. It's a little bit strange to have centralized rate setting in America and have the rates set by the industry who are going to pay those rates. And that's the only way you can call the AMA RUC is an industry association. So Congress can lift that budget neutrality rule. Congress could require CMS to take these steps using objective measures, surgical time, and direct the AMA to really get straight about this and sort of come to terms with what's actually happening. I think these are the sort of medium-term solutions that Congress can be considering. I'll say the short-term thing that can be done tomorrow is to write a Dear Colleagues letter from your member's office to CMS, raising these issues and asking for answers on them. And secondly, to hold some hearings. This is a wonderful briefing. Here we're in the visitor center. I'm so glad you came. Next step is we can raise the profile through actual hearings and committees. So we have some materials available for you, some of the papers that were referenced. You can get to it by going to this bit.ly link in addition to the ones that are some in the back. You can also find all of our emails at this bit.ly link. And can you believe it? With these amazing speakers, we came in on exactly 35 minutes. We do have time for some questions, and I don't know if we may have Representative Trahan step in and say a few words. I don't think I've seen her face yet, but of course now. But in the meantime, would someone like to take the mic and field the Q&A? And we'd love to have your questions. If you want to go ahead and turn your mics on up here.
Hi, my name's Ronnie Elby. I'm a health policy fellow and a research psychologist. I'm serving as a Robert Wood Johnson Foundation Health Policy Fellow in Senator Patty Murray's office, and she's a big proponent of women's health. So thank you so much for all the work that you're doing. I know that you focus on CMS and RUC, but I'm wondering how these issues are also related to GME funding for programs. So for example, Washington State, you showed that map, the 2 programs of training, and then we also talk about the whammy states that we cover, Wyoming, Alaska, Montana, Idaho. So how, they have to train those people, Washington State, and they also have to serve them, and people are traveling 500 miles, as you say. So how can you talk about the GME funding in relation to also your profession?
My role is just to say GME stands for Graduate Medical Education, and then turn to the colleagues, the training centers.
Certainly the GME funding is tied in part to CMS funding, and I think that's what you're referencing. There would definitely be downstream effects if we encourage better funding of obstetrics and gynecology. And you've heard my wonderful colleagues here talk about how about the messaging and the culture that trickles down from the funding that different disciplines receive. It's palpable. So our residents and our medical students who are receiving that funding are also influenced by it just by virtue of the environment that's created. There is a general sense within each hospital and training center that women's health is less valuable and less prestigious. I was going to say sexy because that's the word that a lot of people use. But certainly, I remember I did the Doris Duke Fellowship. It's an amazing fellowship that you're in. And I did Doris Duke in cardiology. And when I told my mentors that I was going to go to obstetrics and gynecology because I saw a real need in women's health that I felt I really needed to address, every single one of them told me, "What are you, crazy? That's insane. Why would you go to that discipline? It's not serious." And obviously that made me think that's exactly why I have to go and train in obstetrics and gynecology. But to your point, it will have an effect there. And that type of culture change is really important. So it might sound like we're saying, please pay us more. We're really talking about how systems and funding fundamentally alter the care that we can give, the valuation that we give to the care of women within our country. It's very profound. So fabulous question. Thank you for that.
Michael Greer, Director of Federal Affairs with NCQA, the National Committee for Quality Assurance. 2 questions. One, have you all thought about the utilization of a quality measure related to the actual procedural outcomes and introducing that into CMS? That way you can do more comparative funding rates based upon patient outcomes for across disciplines. That way it's based on that versus actual care and specialty. Just thinking about another kind of like policy kind of work around a bit. And then 2, can you all talk a little bit about, I know the study you all did a retrospective analysis over 20 years. I read the study sitting here, but I didn't see much in, there wasn't anything really about the impact on the economics of what we see around the physician practices and also employment. So can you talk a little bit about the more macroeconomics that kind of are driving this? So those 2 questions, thank you.
I could probably do the second question. Well, I mean, in terms of the macroeconomics, hopefully this is answering what you're asking. I mean, hospitals are definitely slowing their hiring of gynecologic surgeons, or, it also is a workforce issue, as you say, related to GME, that our OBGYN residencies, let's just say there's 9 people per year, we aren't able to really expand spots because of CMS funding, but also because we're so beholden to providing obstetric services for hospitals that are losing money in obstetrics every day and gynecology. So in order to expand the workforce, we would have to be number 1 hiring and number 2 paying people more. So I don't know if that answers your question at all, but absolutely the hiring for a minimally invasive gynecologic surgeon who largely specializes in MIGS, like Dr. King, if they know, no hospital is going to say, oh, I'm gonna hire a bunch of mixed surgeons who are gonna take up my operating room for the whole day and make very little money when I could hire 3 more orthopedic surgeons and make 10 times the amount. So to the first question, I'll maybe hand that off because you really spoke to the quality thing, but there have been many, many studies done on high value gynecologic surgical care and outcomes and how much, better it is when you actually incentivize people to have more advanced training. But right now, when people have more advanced training, they make significantly less money. So why would someone do 3 more years of school to make less money than people who went to 4 years of school? Yeah, exactly. And I guess I want to say one more thing about the GME and sort of just this like moral, almost like burnout that you feel when you're an OBGYN resident. You're making at that point the same amount of money as all the other residents in the hospital. But you go over to like the orthopedic board and you see the way their patients' rooms look, or how their operating rooms look, or the equipment they get, or the staff. They always have, they're friends with all the scrub techs. They know all the people in that room because they always have the same team. And then you go over to gynecologic surgery and it's like shabby rooms, nurses that are travelers and don't know what they're doing. I mean, there's so many layers to like the moral injury. I don't know if you want to say more.
I think also what you're getting at in terms of thinking of using value-based, like a value-based care model, right? And there are certain conditions in hospital systems that have sort of ventured into that and said, okay, how about we rethink the way that we think of compensation and tie that to quality and outcomes? And guess what? They save money, actually, right? Because I definitely think that would be one way to go. If we are not CMS and we're not this decision making, but I definitely think that that's an excellent alternative.
So one quality indicator you can see in the medical record is just resurgery. How often does someone present with, and have to get 2 or 3 or 4 more surgeries, which is each one of those is pain and risk and expense.
And also currently now, like as a surgeon, reoperation, I guess, or readmission within 30 days, there are certain things, right, that we get dinged for. If you operate on somebody, they bounce back within 30 days. So that model does exist, so it wouldn't be so,
The problem is it could actually worsen this process if you don't solve the upstream. Like if you want to penalize OBGYNs for having bad outcomes, unless you solve the upstream solution to invest in this domain, I think that's where the emphasis is.
As a patient, I try to look at CMS measurements in terms of quality of the surgeon. As a patient, I was interested in a surgeon who had a lot of expertise, meaning the number of years, because the number of years means more surgeries, means less risk for a patient, right? Well, my surgeon had 4 years of actual training, I suppose, on patients out of her education. I knew that was going to be a risk factor compared to the first surgery I had, who was a surgeon who had significantly higher surgeries because he was older, was in the field longer, and yet he did not perform the root cause surgery that I needed. And I think CMS is constantly pushing something that is ineffective. And as many surgeries as somebody does that's ineffective is a higher cost and lower quality of care to have patients.
Another question on the second row?
Yes.
Here. Okay. Hi, my name is Ashlyn. I'm from Congresswoman Sue B's office. My question is a 2-part question, kind of in the same route about politically and legally hostile environments. As much as you can speak to this, I'm just interested in what, how you gauge this sort of situation. But first is, when we talk about CMS reimbursement, there's the Medicare part, which is federal, but then there's the Medicaid aspect. And I'm wondering if you have any insights as to what would make a state perform better or worse compared to another state. And secondly, talking about the residency programs being centered around urban areas also is, let's just say like abortion care is legal there, right? And so I'm wondering how you anticipate the healthcare workforce being
in different environments throughout the country where not all of the care that you should be trained to do is permissible.
I can speak a little bit to the second part. There actually was some analysis that just came out because Match Day was back in March. It actually showed that OBGYN is more popular than ever, even in states that have abortion restrictions. I think that speaks a lot to the angels that do go into this field who do it to take care of women in need regardless of where they live. So in a sense that's heartening, even though, you know, we're here to support, you know, our colleagues have a much more difficult road in those areas. But it is, you know, I think people's interest in fighting against the policies that are hurting women are still wanting to do this with their life, but they're certainly very disincentivized to do it. And then the first question, the Medicare Medicaid question, maybe I'll defer to Chris.
One interesting piece about this is that Medicaid also does not have to follow these same rates, I understand, but they typically do so because figuring out a different set of 12,000 codes is itself pretty onerous. And so it's sort of the path of least resistance is just to copy the codes and pay a discount rate. Like we'll pay 75% of Medicare codes is the way it typically works. So we don't see, at least where it hasn't been well documented, that there's significant variation at this granular level of reimbursing one procedure versus another, even though, of course, Medicaid programs vary in other ways.
Answering your second question about OBGYN training and how that is changing with the current political landscape.
In a state where evidence-based care is restricted and not rooting is intentional, evidence-based care is restricted, does impact the decisions that people make and where they decide to apply to residency. And so residents are choosing not to go to states where they cannot learn the full depth and breadth of evidence-based medicine to take care of women. And what that means is that there's going to be another barrier for those trained physicians to go back to those states to provide care. And we're already seeing states lose maternal units because they don't have enough doctors to staff them. And there is large deserts where you cannot see an OBGYN in places like Idaho that have the most restrictive policies in the nation. And it's easy for people to say that that's going to be an issue that just affects evidence-based care like abortion. It doesn't, because an OBGYN does more than one procedure. And so when you take an OBGYN out of the community because you remove their ability to safely do evidence-based care, you're also removing the person who prevents cancer, treats bleeding, treats fibroids, does routine pregnancy for desired pregnancy care for desired pregnancies, prevention. And so you're leaving half the population without a doctor in that area who's an expert in taking care of them.
It's extremely dangerous, and we're still going to find out what the long-term effects of that's going to be, whether residents who go to other centers to train will come back home to practice and take care of their communities or not. And if we're going to see a widening gap in outcomes for women who are living in places where evidence-based care is restricted. We already know, actually, now that you're more likely to die in those states in our early evidence in the last couple of years, right? You have a greater risk of dying during your pregnancy in states that restrict care.
Question back.
Hi everyone, Akiba Katak, healthcare attorney, background from Cornell and Hopkins in biotech and also healthcare administration work. I'm an entrepreneur for Her Healthy Eyes, an endometriosis diagnostic company to help non-invasively to diagnose this disease, as we just heard today, how tragic it can be, and not only diagnose, but provide a surgical mapping. So this is more of a comment, but also for the staffers, but also a question for all of you, that as an entrepreneur, we would love to work with the providers. You know, we were talking about discrimination and the gaps between that. And then you have a lot of tech entrepreneurs that are coming out with amazing products, you know, with AI to help, you know, the outcomes of all this discrimination, right? And to streamline that. And so our big issue is, yes, we have the tech, yes, you get through FDA, but then the reimbursement and then adopting it and having the healthcare systems and have the providers that actually have it in their hands and they're able to use it. So what advice do you have for someone like me that wants to go and like obviously be a part of that change to help this gap? In regards to reimbursement, I mean, we do get the codes, but then it's very difficult dealing with insurance companies to have the reimbursement rates, negotiated with insurance companies. So how would you approach it as a provider, as an attorney, moving forward to have this for employers? Thank you.
It's definitely a complex system. There's a lot of efforts underway to try to decrease that complexity. The direct answer to your question is you need a lobbyist, you need to go through ACOG, we'll put forth codes for the ACOG check, who put forth codes for your proposed intervention after it sounds like you passed FDA, and it is a very long road. The average amount of time for industry to push new codes through is in the range of a few years. For people like me who are advocating to get changes to codes for billing for surgeries that already exist, it's on the order of 10 to 15 years. So either of those numbers is unacceptable, but the ideal would be a change in the way that they can process that information. To really, and by they, I mean the actual CMS accepting even the deliberations of the rep. It's very bogged down system. To truly create change in that would be a very significant overhaul. But the one good thing I would say from everything I've just said to you is with the right lobbyists, industry has made some great inroads into pushing a variety of interventions forward more quickly because you're able to muster and push them forward. I think you have some experience here too.
I have a master's in computer science from Carnegie Mellon in biotechnology. So a decade ago, I had a business idea. I would say also follow diseases that had success like HIV. Those patients came to the Capitol with Dr. Fauci encouraging patients to continue to advocate for themselves. People that are looking for funding, women are less likely to get funding, but we have, these organizations that just started in January doing great things like being here today. I was disheartened. I was disheartened by healthcare in general, not just looking at women. So finding other diseases that had such success, like rapid drug approval for HIV existed because of the patients, right, pushing government to approve drugs sooner. With the advent of clinical trials taking longer, you can look to COVID, right? We had this massive population that changed it. Endometriosis is not a rare disease. We just don't talk about it as much. I'm lowering my voice when I want to scream. I work with patients that have very rare disease called idiopathic pulmonary fibrosis. There were clinical trials that I work with patients. I help patients do advocacy like I'm doing here today. It wasn't until I had endometriosis that I knew what it was. And I have 3 sisters and I have nieces. So 1 in 4 women get this disease. Men, you will take care of those women. And no, it's not just due to a period. It is very common.
So a question here, microphone in that room.
Hi, I'm from Congresswoman Bonnie Watson-Coleman's office. One of her big issues is the health of Black women and girls. I was wondering how you could speak about kind of the intersection between race and sex, and if it further increases the disparities that you see in this phenomenon.
As a public health professor, wherever you see a problem, the problem is 3 times worse for people of color. And this, I'm sure the experts can talk about fibroids and other issues that are disproportionate.
I mean, for every single condition in gynecology where you identify or name disparity, intersectionality is critically important, right? So when you have multiple marginalized identities, they do intersect and show up in the way that you are marginalized in society and the outcomes that you have. And so I'll speak to like the conditions that I treat, right? In urogynecology, all of our conditions are quality of life, right? So we do what we do to improve people's quality of life. And the treatments are readily accessible or available, I should say. And treatment improves quality of life. However, when you look at, for example, overactive bladder, that affects 1 in 3 women. For Black women, they are 50% more likely to not adhere to medications, treatments, and that's probably due to what the vast majority of the population receives medications that are a little bit higher side effect profile. Less likely to progress to our more advanced therapies, and that's just in one subspecialty. And so yes, the answer is yes, for those who have the intersection of race and gender, and then you can throw on other identities, it's worse for those groups.
Another question, please.
So speaking of groups, I have a rare disease. It's called Reimbursement syndrome. I don't know. Oh, wow. So you add on that layer, there's no codes, right? In the CMS at all. And I feel like working with my health insurance is my second job to try to get anything covered, because when I say that I have a rare disease, they have no idea what that means and they don't care to pay for any part of it. So from the doctor's perspective, I'm consistently, my pelvis is on a 90-degree angle. Even to get a regular gynecological exam is almost impossible, and it takes much longer, so they have to book me for twice the time, of which then they don't want to pay for. So what is your suggestion for me as a patient working with the health insurers to try to get that paid? And then with even like my doctors, because a lot of times their offices don't know how to book for it.
That's a wonderful question. Thanks for sharing your story. I'm also the mom of a patient with endometriosis, so I live the other side of things as well. And even with my level of knowledge, I still have to struggle a lot just to get appointments, to get things paid for. I fight on the phone a lot. I do that for my patients as well. I think at least a few hours every week is devoted to fighting on the phone. The system's clearly broken. What can you as patients yourself, what can you do to best advocate for yourself? The way I teach my patients is to have a binder of your own medical care. Your medical record belongs to you. Be sure to find the champions that you can within your care team, and they might be surprising champions. You know, I'm an obvious potential champion, but it might be your primary care physician, it might be a PA in the office, whoever it is who's really going to help you with those appeals. That's going to be a person that you want to really work closely with and initiate and track your own appeals. But we shouldn't have, and be your own advocate, as you already obviously are. But all of that is my advice to how to handle a broken system. The key thing that we could take away from here is how can we change that broken system? And one, again, this is what we're talking about here, is the devaluation of certain groups of people. Persons who are differently abled, women, persons of color. We're devaluing those people by not funding their care appropriately. And so, here in this space, the thing that we could do is really communicate with lawmakers so they truly understand what that's like. Sharing what your story looks like on a day-to-day basis, just to get a basic appointment and laying that out for people might be incredibly helpful. Because I don't think that without hearing that and really understanding what that looked like, that it's easy for our colleagues and our representatives to really understand the level of the problem. Maybe my recording some of the appeals that I have to get on, which are just these insane conversations where I'm talking to somebody who has no idea what I'm talking about, but is standing in the way of my patient getting the care they need. People need to hear those conversations and share those stories. I think would be how we might start to create change.
I would say one more thing, which is that the take-home message, I think, for a lot of this today is that if we could just throw up some data and show how much more valuable something is and then have it easily readjusted, we would have already done that. But the way the RUC system and the budget neutrality clause is set up, we're handcuffed from making something like women's care, disability care more valuable because we have to take it from somebody else. Yeah. So if we could fix this, we would have done it a long time ago. And that's where the policy piece comes in. So I just really want to drive home that the reason that we're not fixing this is because the system is rigged. And that's what we're here to sort of try to change.
And just one more thing to the point about macroeconomics, gentlemen left the room, but the reason that we can't, so there are some studies that describe how this actually looks in terms of the amount of money allocated to any department, any given surgeon. But all that information in a private, even in an academic hospital is proprietary. So at least within the United States, I can't do a good study to really show you those downstream effects. I can only describe them to you because I'm not going to convince my C-suite colleagues to actually publish that information. So I can only say to you, as was expressed earlier, we can take pictures of our ORs, and an orthopedic OR would be shocked. We can describe the stories of the amount of denials that we're getting right now for women's health care. That's what we have to work with, and it's not as granular as people want it to be, but that's because of the way the system's set up.
Well, let's wrap up by maybe having our final doctor each give a comment, final closing thoughts, and I'll ask Tricia to do so, and then I'll say goodbye.
I mean, I think just to harp on what my colleagues have said, you all are critical in this, and we're definitely going to need to do this together in order to move any of this forward. I think that physicians a lot of times spend a lot of our focus on, our goal is to take care of patients, right? And what we have learned, several of us, is that we actually have to step out of that role a little bit and come talk to the other people that are decision makers. So I hope that you'll stand with us in trying to take better care of patients.
The final word for me is just that we deeply believe that all patients' bodies have the same value to our communities, right? Each of you deserve healthcare and deserve to have a doctor in a hospital system, in a network that cares about you and your health. And the system right now doesn't value the health of women the same as everybody else's health. And so that's wrong. And we deeply, deeply believe in finding ways to fix that system. And we hope that you will use your avenues of influence to help us find a way to institute change.
The impact of this disease is not just limited to gynecologic surgeons. I actually needed a colon rectal surgeon to understand this disease too. There were 2 surgeons. So this is an interdisciplinary medical issue where women's bodies may seem like we're just in a box. Blow up that box and think about how advanced our healthcare system could be once we do that.
Thank you all. I'll just say, what we suggested is the next step, if anything, is to, I hope, raise the education and the profile of this issue. And then I think send a letter to CMS, and that would be the ask for your member. If your member is interested in raising the profile of this issue, that will keep the ball moving, keep the question alive. And so to ask about that, contact Liz Powell or any of us. And I want to thank Liz Powell for your central role in putting this all together.